So the doctor that refers is hoping that maybe you have come across something similar.
Okay.
He has swelling on his buttocks due to what we thought was a bone infection. However, he just did some blood work and they haven't found infection on the blood, so that kind of has puzzled his other doctor. He does want you to like call him.
Communicate with Dr.
So,
saying good night.
You have a cell phone number or a pager?
told us that the nurse can connect him right away. He's at the Southeast campus, I guess it's called, the one on Ajo.
Yes.
The European.
Is that your primary doctor?
No.
He's my infectious disease.
Have you been seen at UMC ever? When was the last time you were inpatient? That you've had studies or x-ray studies?
Last year they pulled the liquid out to see what it was, because this is a chronic thing. It's been happening for about 4 years. So there's several records there with.
Well, there's more than one of you here. A second? Yes.
It's interesting because about 2 weeks after I started to have the infection started about 4 weeks ago and started to get really big about 4 weeks ago, and then about 2 weeks ago then it finally started to cool down and just cool down and not give me pain. I'm not supposed to feel that area, but it's kind of a tricky area because sometimes if there's enough pain, I guess maybe I can feel the area a little bit. So last week I did some push-ups and it seemed to inflammate or anger the area again, and so I've been laying down, which I normally do. I lay down about 90% of the day. I lay down on my belly about 90% of the day, and I've been laying down since then, which I normally do, and yesterday it was like a semi-comfortable tingling numbness again, and that's how it was after the 2 weeks. The initial, it felt like somebody was screaming at me, yelling at me. It's horrible pain. It's very uncomfortable. But then about 2 weeks after that, then it started to be like a semi-comfortable tingling numbness, and then that was cool for a while, and I thought, well, maybe because this is usually when my body reabsorbs it, and then I can piss it out, but nothing happened. It just seemed to stay the same size.
You say piss it out, what do you mean? Does something actually drain out?
I think it goes to my bladder or something like that.
Why do you say that?
Well,
because it gets smaller in size.
Yeah, it gets smaller in size.
You don't actually notice change in your urine?
Not really.
Okay.
Yeah.
So that's a hypothesis.
Yeah, it's kind of a hypothesis.
Casual hypothesis.
What he thinks, yeah.
All right.
This started like 5 years ago, and the first time the swelling was so close to the anus, the doctor thought it was better not to had it touch so that it wouldn't travel to that wall and get it worse. Then they gave him some medication. It went away for about a year.
They gave me some Avalox, I think.
Yeah. Okay.
Yeah.
So it went away, but then it came back in a different shape. And first it was this way, and now it's like a pear. So, but then they give him some more antibiotics, and they didn't do as much. It kind of got small, but it didn't go away.
Do you always have a sore on your buttocks? Is there always full thickness?
Mm. Swelling?
Sore, like an area where there's drainage or an open area in your skin. That's
That
what I'm
was on
talking
the
about.
front. He used to have a, right here, a
Mhm.
sore that would get paused, and
Mhm.
then that disappeared,
Mhm.
and we thought that it traveled back.
Okay.
Did
Girdles down here, took out the top of your hip,
exactly.
and that would drain out
And then they did the
chronically.
they see they took out the bone, and
Uh-huh.
then my body didn't close out that
Uh-huh.
void,
Uh-huh.
and so they did a muscle flap
Swung some muscle
from
over.
here,
Oh boy, yeah.
and they put it in there, and then they closed it up, and Dr. Demas, I don't know where he's at right now, if he's still in Tucson or
I've
where
heard
he's
the name
at.
before.
Okay, he would he he I went and saw him, and I don't know, the silver sulfate or
Mhm.
silver whatever, and he would dip it in there because
Get it to
every
scar
once in a
down and
while,
close.
yeah,
But it would still do this intermittent eruption of some type of fluid.
exactly,
Yeah.
And
serious
when
fluid,
that
and
disappeared, then we started seeing the other
At the
stuff.
other end.
the
It's got to get out
last
some way.
yeah,
Yeah.
the last time that it happened, then I didn't fuss around with it. I usually clean it, take care of it, make sure it's cool and stuff like that. But the last time I didn't really fuss around with it, and it just kind of went away. But I think that it might have tunneled around to the backside,
Mhm.
you know, the swelling might have tunneled
I
around to
agree
the
with you.
backside.
Yeah.
But
It likes to go with gravity.
the other doctors haven't agreed with us. They think that because he has so many sores in his buttocks, that maybe that has traveled to the bone. So that's their theory, but nobody really knows.
Yeah.
So.
Fundamentally, it comes down to an issue where there's probably a chronic infection in that area that goes and comes at bay with some antibiotics and some drainage, and your body's able to clear it for a period of time, and then either through introduction from the outside or just basically those bacteria revving up again, reaccumulating an infection and abscess, and the only way it goes away is to eventually reach the surface, and you say piss it out. It's likely draining out somewhere, draining into a dressing, draining into clothing or bedding or something like that. And it went from coming out intermittently in the top here to now it's going out intermittently at the
Yeah.
bottom, or wherever you can find the path of least resistance for the most part. Then it kind of comes down to what you do about something like this. And so you've had a particularly bad episode in the last 4 weeks. Is that a true statement? Where this
Yeah,
thing got big? Is it
yeah.
not going away now? Is that the deal? Or?
Not going away.
It about a year ago it was fine because the I was on Avalox and vancomycin or something, and then they did an IV in me, and so and I think they gave me Avalox, I'm not sure, and it finally took, and I was laying down about 90% of the time on my belly,
Mhm.
and with the Avalox, I don't know if it was just a coincidence. My wife is saying just it was kind of a
No.
coincidence. She's not sure.
No, because the last time that he has this, it was from uh, from July to November,
Mhm.
and on November we decided to stop the medicine because it was not helping. And the doctor said, well, you have to have surgery to explore, or you have to leave it alone. So we
Which
decided.
doctor was this?
The Sangonite,
Saying
the
I would
infectious disease doctor at South Campus, and so we decided to leave it alone and leave the medicine, but it was staying at a certain size. It wasn't too big, but lately it's about 2 months where it started to get real big, and I noticed that he's more depressed. That's one
Yeah.
of the things, since he cannot feel
Yeah,
totally.
yeah.
So
It's
I
different
knew that it was
manifestations.
bad on him, so I said we have to do something
Okay.
about it. But it
Let me
hasn't
take a
gone
look
away.
here. I'm gonna get. Are you able to get yourself up here? Do we need a hand? I'll be right back. 1 second.
Do you want any immobilizer, or do you want this?
Yeah, but that medicine is not the solution. But remember what Dr. Sang and I say. Maybe you have to do a biopsy to know the right kind of medicine so that he can attack it.
yeah, but I mean the time before.
Before, that time before,
That's
yeah.
what I was
since November stayed 5 days. So he wants you to get up here, Papa. This is the front, I think. I think he would be able to see it better. Ah, but he's thinking about this. Maybe that's why he's more focused about the front.
Alright. Ready for action?
Check it out.
Yeah, whatever. So how do you care for yourself here? What, do you do packings daily or anything?
Oh, there's
Nothing
no
to pack?
opening. Yeah, there's no opening or anything like that. It's just swelling. Hasn't busted.
Yeah.
This is actually small, dude.
Small,
Yeah,
relatively?
because he's been laying down a lot.
Interesting thing is, it's not that hot.
It's not hot. It's not comfortable to touch. And that's what I was telling you about when I did the push-ups, and I think that has to do with arching. I think it irritates the area somehow, and it pisses the area off. And then about 4 days ago, I did some push-ups, and they irritated it. But then yesterday, then it like cooled down. It was nice. It felt like I said, a semi-comfortable tingling numbness, and that's the way it's been for a little while, and that's usually, a good, that means that everything is okay.
So it's tough, it's tough to invoke this as an infection because they usually look worse like this, they don't get better, and you'd be pretty sick.
Yeah.
You know what I'm saying? And I'm wondering, has anybody aspirated this?
Yes.
Put a needle in there. And what's the analysis on that?
Here, they didn't find any infection on it.
And the next day after they asked for it,
It filled up right away.
yeah, it filled up. So, and I don't know if that was because I was sitting a lot that day afterwards, or I don't know.
Alright. Are you comfortable laying like that?
Actually,
Pillow or
this is
something?
better than laying on my back.
No, he doesn't
No
want
pillow,
it. Yeah, everybody else.
Yeah.
Yeah, that's kind of how I sleep. Like that. It's hard to get a pillow in. So.
The doctor pulled blood and they had see infection, and he had suggested that maybe to do what did he said it was called, John?
I don't know what you're talking about, honey. He said I should go to a specialist. I don't know.
No, yeah.
So your options are, this is a fluid collection. People get fluid collections in areas that are related to joints. If you've ever heard of a Baker's cyst in the back of the knee, people get meniscal tears. They'll fill up these big bags of loose capsular tissue. I know this isn't related to your knee, but it's an equivalent. You form bursa in areas of friction in your body. They're universal. There is an area of friction that exists between your femur and your pelvis, and you likely have a large bursa there. You know what I'm talking about? Between the remnant of your femur and your pelvis. And that area is a large bursa, and it is going to generate fluid. If there's a path of low resistance for that fluid to go, which it may be into this area, this may represent bursal fluid or joint fluid. You talk about pissing things out. I don't know. I know you don't necessarily mean that literally, but it is theoretically possible that this could represent a bladder or a cystic communication into this area. I mean, the things are separated by like a centimeter in this area, so anything's possible in that regard. Relation to your bowel, probably not, because it would be infected immediately. Do you get urinary tract infections?
No.
Not lately.
Not particularly?
It's been a little bit dark lately, but that's just
Dehydrated?
because I've been laying down so much on my belly. Doctor, I've been trying so hard to just lay on my belly and I don't want to irritate that area at all.
You're doing a great job of taking care of yourself. I mean, we see some people who get some real problems with skin breakdown, and everybody gets it eventually. But I mean, that doesn't seem to be your issue right here. I guess the fundamental is where is this fluid coming from? And there are some analyses that we can do to determine if it's urine. Look at the creatinine content. If it's concentrated high in creatinine, we can see that it's actually urine. I think that's worth looking at. I don't know if that's been done before. I'm going to call your primary and see if he has any familiarity. I'm sorry, not primary, but the infectious disease doctor. Is he the one who did the aspiration, or is it somebody else?
No, it was somebody else.
Was that
At
UMC?
UMC. How long ago? November last year.
Okay, so let's take a look at that. And then looking at joint fluid, I'd have to call the laboratory to say exactly what we should get to determine if it's joint fluid or not. We do joint fluid analysis, but that's when we know that it's joint fluid. It's a little bit different than trying to say, is this joint fluid or not? Is this a bursal type fluid collection or not? And then it comes down to what do you do about it? Well, if it's cystic, then you're off to the urologist. Cystic is related to the bladder. If it's bursal, related to the hip, that becomes a little bit trickier because anywhere where you have two things that are rubbing against each other, it's going to generate fluid, and you need to move your leg. There are people who get further femoral resection, they get it taken down farther because they don't tolerate having this riding up into their hip. You seem to tolerate that pretty well. This is fairly unique situation.
What do you mean further femoral?
So if you would take the femur lower,
cut it off, cut off the leg.
Yeah, and then your leg's real floppy.
Yeah, I'm not digging that, man.
No, but that would remove the fluid generator. That is the two things that are rubbing next to each other. That's what I'm talking about. But it would be hard to ablate that space because your body's going to want to regenerate that space.
Oh, I don't know. It's just probably a lot more important things to talk about.
What's that?
I was just wondering about the stem cells and the regrowth of bone in that area, and how would it screw things up? And could they put in a composite so that it would composite so that the femur, so there would be a ball and socket in there again, and so that they wouldn't bump together, or
like a hip arthroplasty, something like that? The issue with that is in people with neurologic deficit in the lower extremities, they dislocate almost immediately. And then you end up with the same situation where you have a dislocated prosthetic hip where there used to be a stable situation. As far as some type of graft, there's a fusion, but you really don't want a fusion. Then it makes going from laying to sitting and mobility and perineal care an issue. It's hard to function with a stiff leg. We do it in some people who are up walking around when they lose their hips for various reasons, and we fuse young people. That's not going to be a very functional solution for you. So we're going to have to think about this a little bit, okay? It's not going to be a slam dunk. I'd like to figure out what the fluid is, first of all. May get another MRI to see if we can see where that tracks. And I may talk to the interventional musculoskeletal radiologist over at the university about potentially doing a cystogram, or what we're calling this is some sort of a bursalgram to see what this communicates with. If this is all communicating with the hip space, then super, this is a bursa, an aggressive fluid-forming bursa that may or may not occasionally become infected. When's the last time you've had drainage out of there?
5 years ago.
Yeah, so I think this is a sterile situation in any regard, and most likely related to, number one is bursa, related to the articulation between the hip and the femur and the ilium. Number two is some sort of, like you said, bladder communication.
Is that
possible?
The time that my wife was talking about was the last time was whenever there was swelling that accumulated, but then it didn't really go down. But then I was talking to my wife the time before that, when I was taking the Avalox or the vancomycin or whatever it was, then it went down to normal size. But then like we were talking about this last time, not this time, but the time before, it got big and never went down
Mhm.
again, so, you know.
And you know, that's kind of exactly what a Baker's cyst is. So people get swelling in their knee, it increases the joint fluid production in their knee, usually due to irritation, inflammation, degeneration of the knee, and then it creates a rent in the capsule of the knee, and all that fluid pushes out, and it stays out there, it stays in this bag out there. And so when you have an increase in the irritation, fluid formation in that bursa, and then say you move in a different way, it acutely increases the pressure in there, creates a little herniation in that bag that normally exists that contains that fluid, and then it pumps it out into this nice low pressure potential space. It doesn't have a tendency to want to go back in. It wants to stay in that area.
I see.
And we do occasionally have to ablate Baker's cysts, and we take them down. The problem is they have a tendency to come back. We have sclerosing agents that allow tissue compartments to squeeze down and close down and scar against each other.
I think that's what Dr. Zhang and I, with the infectious disease